The Parkinsons podcast is brought to you by the Davis Phinney Foundation and brings you the stories, wisdom, and expertise of people living with Parkinson's, care partners, and Parkinson's professionals. In this episode, Dr. Yasar Torres-Yaghi answers questions about off time in Parkinson's, including symptoms, medications, deep brain stimulation, and more.
My name is Dr. Lauren Costantini. I'm a member of the Scientific Advisory Board at the Davis Phinney Foundation. And I'm really looking forward to this conversation because we're going to talk about an issue that is relevant for nearly everyone living with Parkinson's, and that's off times. So welcome, Dr. Torres-Yaghi, and thank you for agreeing to be our guest today.
My pleasure. Thank you for having me.
Just to tell you all in the audience about Dr. Torres-Yaghi, he's a movement disorder specialist and assistant professor in the Department of Neurology at Georgetown University and co-director of the Lewy Body Dementia Clinic, spearheading an initiative to care for a growing population of aging patients with neurodegenerative conditions. He has a broad background in clinical research with specific training and expertise in Lewy body dementia and atypical Parkinsonism, and has been an integral member of numerous clinical trials. So let's get to it. So first question is, what exactly is off and what are the different types of off?
This is an amazing first question.
Right.
So off is something that, first of all, you need to be on the same page with your patient about. I still remember 34 years, including preschool, is how long it takes to become a movement disorder specialist. And I was in my 33rd year doing my first year of my fellowship, which is you become an MD, then you do your neurology residency, then you do a 2-year fellowship if you want to do clinical research in movement disorders. Still remember my first patient. What off meant to me was different than what off meant to my patient. Actually, off to my patient meant that the Parkinson's was off. So my patient was explaining to me, he said, I'm off at these times of the day. And I said, well, we have to fix that because he sounded happy. He said, I'm off all the time. It's just amazing. And I said, okay, well, that's great. And so I left the room and I said, oh, well, my patient's doing, very happy, but he's off all day. And so I came back in the room. I said, wait, hold on a second. So when you said off, you mean Parkinson's off, right? For a movement disorder specialist, when we think off, we think a return of Parkinson's symptoms, right? So that means that your medication has worn off or it hasn't really kicked in yet. And people feel that their Parkinson's symptoms are back in action. Their tremor, rigidity, stiffness, slowness of movement is all present. And that can come in all shapes and forms, and it can enter our lives differently from moment to moment. It's not always the same. Not all off episodes are equal. And so you can have it in the morning, for example. Morning off means I wake up in the morning. It takes me a long time to get ready. What that means to me is that it's been many hours since your previous dose of carbidopa-levodopa, right? So maybe you took your last dose at 8 p.m. and hopefully you wake up at 6 a.m. or maybe even later if you don't have a 3-year-old like me. And you wake up later, you say, I've taken my medicine and maybe it takes a little bit of time before it kicks in. That's a morning off. Now, wearing off just in general means you've taken your medicine, it's kicked in, it's working. Maybe it works for 3-4 hours. Maybe your next dose is due 5 or 6 hours after your previous dose was given. And you have about a 1 or 2 hour period of time where you feel those symptoms reemerge. That can happen just after your dose is given, 3 to 4 hours, for example. It can happen precipitated by actually eating. So if you eat a high protein meal, like let's say at lunchtime, you're doing the right thing, you're eating, some protein, which is good for your body, but it reduces the absorption and the effectiveness of the carbidopa-levodopa. So that can happen. The other piece here that's really important is understanding that off also includes the time it takes after you take your medicine so that medicine kicks in. So sometimes that can be on average, sometimes 60 minutes. So people might say, doctor, I take my carbidopa-levodopa and I feel worse for about an hour right after I take it. And I say, well, we have to investigate, but it's possible that what you're experiencing is that time it takes before that carbidopa levodopa takes effect. That counts as off time. One more, because look, 34 years, including preschool, we have to identify these offs, because how you communicate with your team is very important, the healthcare team that takes care of you. Let's not forget nighttime. Let's not forget 2, 3 a.m., 4 a.m. in the morning. Our patients might wake up, feel restless, might be hard to turn in bed. Maybe their Parkinson's symptoms are bad. Maybe their Parkinson's symptoms wake them up, but then they have to urinate. That could be an off episode, right? So sleep fragmentation in the middle of the night is also something that we always need to screen for to make sure that we're not missing that aspect of off that can happen at any moment throughout the day.
And it sounds like these different types of off can happen within one individual at any time. Is that right?
Very good question. And I think it can happen differently. It can be predictable or it can be unpredictable. And then another feature can be tolerance, right? They can be tolerable offs and sometimes intolerable offs. And so that's a very, very important question. Every time in the back of my mind, when I was being trained to really analyze off as a movement disorder specialist with subspecialized training, thinking about the more modern advanced therapeutics, we always need to figure out, first of all, is this happening predictably? Can a patient tell me, it's really happening every 3 hours after taking my previous dose? That's a pattern, right? If there's a pattern, that's helpful for us to know. Or like we said, eating. If you eat and you feel like you wear off of your medicines more easily, that's also an important pattern. And then that morning off, that can be a pattern, right? And there's different ways to analyze how to treat those different offs.
Interesting. So what types of symptoms might a patient experience when they are off, besides the ones that you had just described?
That's a really good kind of neuroscientist question, because you got it. It's the brain is complicated, as Dr. Costantini knows. The brain it's not a straightforward organ, unfortunately for all of us, right? It's a very important organ, but it controls a lot of aspects of our body, right? It controls our neurologic state, right? Our neurologic state's very important. Our brain capacity, our memory, our cognition, our alertness, right? It also controls our ability to move, right? There are certain centers of the brain, like our Parkinson's circuitry, that can be affected. We might see tremors, rigidity, slowness of movement, gait impairment, falling. Those are the motor symptoms that might happen. But also the brain can control our psychology, right? Anxiety, depression, right? This is an organ that it can affect our behavior, our neurologic state, our movements. And so it's very different. It's unique in comparison to the other organs of the body. Also, there's a nervous system throughout our body, right? Our nervous system controls our other organs. So it really is a multiple system type of condition, especially off episodes, because it's those non-motor symptoms, not the motor symptoms, those non-motor symptoms that also can be hard to detect. And those are the things that we talk about. Things that are very underdetected based on research are things like pain, right? Pain can be a symptom of wearing off. And that's something very, very important to detect. Brain fog. Some patients might feel like I'm just cognitively slowing down. It's like my cognitive agility isn't at its full capacity. As a Parkinson's specialist that also handles patients with cognitive impairment, I see that a lot, that I need to be able to distinguish between true cognitive impairment or a cognitive effect from a wearing off episode, if it can happen episodically. Panic, anxiety, depression, all of these things can be part of wearing off. Sweating can be part of wearing off. So all of these things, we have to combine them together to understand, hey, is it just one a la carte thing that's happening? Some patients might experience just a little bit of anxiety. That could be a symptom of wearing off. And sometimes those non-motor symptoms do not necessarily happen in combination with the motor symptoms. And sometimes they happen solely motor symptoms that occur, and sometimes it's a combination. So this is a very intricate conversation. I'm so happy that we're having it.
Sounds more complex than we had originally thought. So you had mentioned earlier L-DOPA. Do off episodes have to do with the types of medication you take and your medication schedule, or both? Obviously, a lot of patients are taking more than just one type of Parkinson's medication. Does that play a role?
Yes, and you got it. You're just nailing it with the questions, because it's carbidopa, levodopa. We think of carbidopa, levodopa as our dopamine repleter, right? When I teach, I'm an academic neurologist. That's why I'm stuck in the river, the Potomac River here, with Georgetown behind me. But when we teach our medical students, residents, our fellows, our goal really is to teach them about what it is that we're doing. Our role as a physician is to identify a problem and think about the therapeutic solution to that problem. So wearing off occurs traditionally, when we think about it, in between our doses of carbidopa, levodopa, right? They can either happen, like we said, in the morning, in the evening, in between, due to diet, et cetera. And so when we think about it, it's traditionally thought of, as a function of the medicine either not being absorbed as adequately as it could in patients maybe with constipation or because of diet, or it's wearing off early. The effect as it's in your system wears off too early. But the way we practice, as you mentioned, is to combine therapies, right? So we think of carbidopa, levodopa, and we give that multiple times a day, but there's a lot of reasoning behind adjunctive and combination therapy. We call that rational polypharmacy. Not irrational polypharmacy. That's not what we want, right? We don't want our patients on a million medicines, although that sometimes happens. We have our patients on so many meds. But the idea is, how is it that we really kind of combine and create a cocktail approach? We use adjunctive medications. And those families of medicines can be monoamine oxidase inhibitors, dopamine agonists, and there's different medications within each category. You can think about other formulations of carbidopa, levodopa, extended release formulations to help potentially extend the duration. You can think about COMT inhibitors, which are medications that might prolong the duration of effect of carbidopa, levodopa. And now we have multiple other avenues, right? We think about the medications that are derivatives of amantadine, which can help with wearing off and dyskinesias. And then we have other medications like A2A receptor antagonists. Those are adenosine 2A receptors antagonists. That's another family of medication. Those are the medicines that we combine together. And now we have as needed therapies, right? We have medicines that can be given as needed for patients that need an on-demand or an as-needed way of rescuing them from an off, to get them from an off state to an on state so that they feel better.
Excellent. Fantastic. So I'm a big fan of nutrition and hoping to change the body through what we eat. As you know, things that we put in our mouth every day play a role in our physiology as well as our disease state. So are there any nutritional choices like hydration that can play a role in off times and improve or even cause a problem and increase off?
Great. Yeah. I think it's a very important topic. Thinking about the condition that we all deal with in our world, our dopamine deficiency condition, thinking about it holistically, and not just, I'm talking a lot from an MD allopathic lens, talking about modern therapies, therapeutics, but there's so much more to life than medication, right? Sometimes it doesn't feel like it because we have all these, wonderful medications at our disposal, but it has a lot to do with lifestyle and diet and exercise. And so these non-pharmacologic measures can make a difference in our life. Exercise is important. Diet is important. Sleeping is important. Hydration is important. Especially in patients with Parkinson's disease, we might actually feel low blood pressure. So low blood pressure actually can be part of Parkinson's, not necessarily part of off, but you can see blood pressure changes, this volatility of blood pressure. Especially with off episodes, we might actually see sometimes the blood pressure come up. And so it's important to manage all aspects of our body. Hydrating is important in terms of recommendations. We try our best to adequately hydrate. We usually say, it's kind of that old adage, 8 glasses that are 8 ounces big of water in a day, right? That's 64 ounces, a little bit more than half a gallon. And then our patients say, but then I have to urinate a lot. And I say, I know, that's the drawback, right? We do, unfortunately, have pluses and minuses to everything. The other thing we say is that diet is very important. Diet actually can dictate how we sleep. The better we sleep, the more deeply we sleep, the better our days are going to be. But we usually say for a good brain healthy diet, we consider the Mediterranean diet, right? So the Mediterranean diet is something that is usually high in vegetables. It's a very colorful plate, right? Maybe half of your plate has color, might be fruits, vegetables, whole grains. You actually have a lower carbohydrate amount as part of that diet. And you do, in fact, have things like fats and protein as part of that diet. But then that leads us to the second part of Dr. Costantini's question is, are there any drawbacks? And I mentioned it, we alluded to it earlier, but protein can unfortunately reduce the absorption of carbidopa levodopa. And I don't want to overdo it because I don't want people, because what ends up happening is when you're on a medicine multiple times a day, like a carbidopa levodopa pill or in any formulation, oftentimes we're on it multiple times a day. And patients might say, but when do I eat? You know, how am I supposed to eat when I'm eating and I'm supposed to space my medicine away from food? So that's a very individual conversation. And so it's important to know, but I don't want it to alter our way of thinking. And then one last point on diet. Constipation is one of the non-motor symptoms of Parkinson's disease. And so imagine we have our upper GI tract and our lower GI tract. Constipation is something that we suffer from, but also esophageal dysmotility. Sometimes it's hard to bring food down. Our stomach does not always empty into the small intestine. And so that kind of dysregulation makes it even harder for us sometimes to rely on the pills that we take orally so that they take us into an on state from an off state. And that's part of the problem of wearing off. And so one of my first questions, whenever a patient calls us and says, you know, it feels like my carbidopa levodopa isn't working as well as it used to, or our medications to help us with movements, they're not working as well as they used to. The past 3 days have been really rough. You know, the first question I'll ask is, are you constipated? And patients will say, wait, hold on a second. And they'll think, some will say no. And I'll say, wait, what do you mean you're not constipated? They'll say, well, I had a bowel movement today. And then I go even deeper. I say, wait, did you fully evacuate? If you didn't fully evacuate, if you're straining, if it's hard to go and you're noticing, even if you're going, that still is suboptimal bowel movements. And so our goal really is, it's a multimodal approach. If we can have you eating properly, hydrating properly, that's where hydration is a major piece, right? If you're hydrated, your colon is going to move that stool down. Hydration is important for bowel movements. Exercise is important for bowel movements. So all of these things come together.
Excellent. Perfect. That was another question is, what about off episodes and exercise? Sounds like that just exercising is going to help some of these other problems like constipation, but could they have a direct effect with off episodes, exercise in general?
Wonderful, wonderful question, because that is a tough one. You're right. You know, that making that connection is a tough one, and it's a very higher level question, because you got it. So exercise is very important. And we kind of talked about the reasons why exercise is important for your GI system. Exercise is also important to help increase endorphins. Endorphins are good for your muscles, good for your brain. It's good for your alertness. It's also, when you exercise, based on animal models and based on what we know, if you see if you study the chemicals that are elevated, there's something called a neuronal growth factor that is increased with exercise. That's very, very important for your overall functional state. And it might be really good. That neuronal growth factor might be very good in maintaining the health of your nerves and your brain. And then the third part about exercise that's important is that there's a concept called neuroplasticity, kind of retraining the circuitry of your brain, right? We have different circuits that lead to movement. In Parkinson's disease, we have our basal ganglia circuitry that might be affected, but there's different circuits that help us move. And so you can kind of strengthen the other circuits and the circuits that are affected in Parkinson's disease so that we can walk and move and be more functional and in a more smooth fashion. So the more we exercise, the better we're going to feel. And that may have a positive effect on the amount of off time that we have. One last point on that is, it's not uncommon for patients of ours to do what they're supposed to do. They're trying their hardest. They're trying to feel better. They're trying to exercise. They're trying to go to their physical therapy. We know how important physical therapy is. And an off episode stops them from being able to do that. So it goes both ways. we need to tackle off in order to exercise, and we need to exercise in order to kind of beat off. And so both of those things are very important. That piece of if off impairs our ability to exercise, or off impairs our ability to go for our physical therapy session, that's an important point. And we have to be able to have maybe an on-demand strategy in case that were to happen in an unpredictable fashion, because I don't want my patient to miss their physical therapy appointment. I want them to be able to feel better if they're in an off state. Maybe we can get them back in an on state so they can exercise.
Yep. Mind-body connection, it's important. So one question here from a patient is, are there safe ways to extend the life of your carbilevodopa so you have less off time? Sounds like the gold mine question there.
Yeah, and that is a debated question. Yeah, it's a gold mine question. So, it's a tough question because there's different ways of looking at this. Because it's very much an individual conversation, and it's a personal one in many ways to everybody. But the way I kind of describe it is, we want people to feel as functional as possible. And so, as we mentioned, we don't want our patients not to be able to move, not to be able to walk. We want them to be at their optimal capacity so that they can exercise, so that they can walk, so that they do maintain functionality over time. And how we do that is to try and maintain what we call dopaminergic tone. We want that tone to be as steady as possible given our oral medications, so that our patients can feel that stability. And so it's very much, I believe, it's very much dependent on each person, but we don't want to overdo our dopaminergic tone, right? There is a therapeutic window that our goal is to stay within that therapeutic window, so we don't supersede that threshold into dyskinesia, and then so that we don't undershoot, so our patients are experiencing multiple hours of off time in a day. And that's where that multimodal approach to therapy comes in. There are ways to extend our on time, with therapies, exercise, lifestyle modifications. All of those things can help kind of extend that duration of effect throughout the day. But the overall longevity of that effectiveness from our medication is very much dictated by the way the condition progresses. Mm-hmm. So if the condition progresses, that's the true function. When you think about the function of the cause, I think the idea that medication may not last in terms of longevity, in terms of effectiveness over many, many years, is very much based on how the condition itself is progressing.
You led me right into our next question on the list here. Do off times increase when Parkinson's progresses? Is this a function of the progression of the disease, or because the medications are no longer treating symptoms as effectively?
Yeah, great. And I, there's a lot of ways of looking at this, and there's data out there, about the utility of using dopamine sparing medications versus just using dopamine or levodopa, dopamine sparing strategies. Now, more recently, there's been a lot of scientific and clinical discussion about kind of this continuous dopamine type of therapeutic strategy, kind of keeping everything as continuous as possible. And so there's different ways of thinking about it. But what we do know is that over time, as the condition progresses, we know that the overall amount of medication that is needed can increase in order to provide benefit. And we're seeing more and more off time as the condition progresses. And so anywhere between 5 to 13 years after either disease onset or the time that we start our medications, right? There's different start points that have been studied, but ever since, because when we think about the progression of the condition, because it is a progressive disorder, we have to think about the more and more need to address off as the disease progresses over years, usually 5 to 13 years after, we might see more and more off time start to develop. And another way of kind of categorizing off time is actually talking about it just as return of symptoms, right? Peeling off that extra layer, just saying return of symptoms in between doses does tend to progress, become more pronounced, and the duration of those time periods does tend to get worse.
Yeah. So what are the most effective ways to treat off currently? Pharmacological, you mentioned a couple. I think people want to hear a little more specifically about some of those on demand. And are there any non-pharmacological or even surgical ways to treat off?
Yeah, you got it. So this is the joke is the 34 years, including preschool. This is why, neurology has become so subspecialized, right? And clinical neurology has become so subspecialized that a movement disorder specialist can be very helpful in analyzing these sorts of scenarios. Similarly, an MS specialist for multiple sclerosis will be much better suited to be able to handle a 2021 case of multiple sclerosis because of the advancements in therapeutics, both in movement disorders and multiple sclerosis. And so this advancement in therapeutics has kind of paved the way for the need for more subspecialization within neurology. So the positive about all of this is that, hey, look at all these medicines that I mentioned, right? Dr. Costantini was like, wait, I just asked one quick question and you're talking too much with all these things, but you got it. There's so many families of medications and now there's different categories, right? You said, we want to hear more about those on-demand therapies. Hey, look, just since 2017, there's been this development of on-demand therapeutics. So let's start with there, right? So on-demand therapeutics. So traditionally, what we may have done back in the 1970s and 1980s is, hey, take an extra dose of carbidopa levodopa. Hey, that's a way of thinking about treating an off episode, right? In between your doses, if you're having an off episode, maybe you can take an extra dose right here or there. And that's, again, very individual. So it has to be planned by your healthcare team and each individual person. That's one way of thinking. Now, but that still doesn't bypass the problems that we run into with the gut dysfunction, right? And so you might be doing the right thing by taking your medicines orally, but what are the medication options that are on-demand therapies, that as needed therapies that might help us bypass that GI tract? We have injectable apomorphine, right? Apokin. We have an inhaled option with Inbrija or Inbrija, right? I've been told Inbrija because it's supposed to bridge you till your next dose. Depends if you're what coast you're on, but I guess I say Inbrija, but it really kind of has this idea of bridging you till your next dose because you're using an inhaled option in an on-demand way for off. I'll stop there and clarify any answers Dr. Costantini does.
Are there any non-pharmacologic or even surgical approaches for off specifically? I don't think in my knowledge that there is, but.
Yeah, so, well, you can think about them as maintenance therapies, right? So surgically, yes, those we call them surgical treatment modalities, right? You got it. So that's exactly kind of where there's now a continuum, right? So we think about the condition as a continuum. If we are experiencing motor fluctuations or wearing off, and we're at a stage where we need to consider surgical treatment modalities, there is a medication infusion port that actually gives carbidopa levodopa intestinal gel on a reliable and consistent basis through a medication infusion port directly to the small intestine where the carbidopa levodopa gets more effectively absorbed. And that's pumped. It's a pump basically that infuses medication on an hourly rate. And that allows us to fine tune, the amount that we're actually giving by 0.1 ml increments, which equates to 2 milligram increments. Imagine being able to titrate, go up and down by 2 milligrams per hour. That's an infusion port. What we have also at our disposal are 3 kinds of deep brain stimulators, right? So there are the different kinds of deep brain stimulators that we can place, and you put them in different parts of the brain depending on what sort of condition we're dealing with. There are 3 main targets. There's more, but 3 main targets that we think about when treating tremor and Parkinson's disease for deep brain stimulation.
Excellent. Okay, well, we're about halfway through our timing, and we want to now switch over to questions from the attendees. So Lee is typing them out for me here. We've got 5 questions so far, so I encourage all of you listening to start typing in your questions in the chat. So first question from our attendee is, what is your experience with the NuPro patch, and does it help with wearing off?
Yeah, great question. So Nupro is a dopamine agonist, right? So it's a patch. It's transdermal. We call it transdermal through the skin. What makes it unique in comparison to the other dopamine agonists is that it is a patch, but also that it's an extended release formulation, right? So we think more extended release, right? We think about more extended release, carbidopa, levodopa. We like to use perhaps, depending on each case, but extended release formulation of dopamine agonist. But the Nupro patches is a helpful tool to help kind of think about, creating some sort of stabilization of benefit. So it could, yes, dopamine agonists like Nupro could be helpful in extended release form to help reduce wearing off. That's the short answer. There are risks and benefits to each drug class, right? And so we think about dopamine agonists as their own drug class, different than the other drug classes. But really what dopamine agonists are, and so we can conceptually think about them as a pharmacologist, right? If we put on our pharmacology hat, what they are molecules that they're like dopamine imposters. They sit on dopamine receptors. These are receptors, by the way, or like little cups. And then the molecules sit on those receptors on the neurons and act like dopamine would act. They are not dopamine. Levodopa actually enters the neuron and converts into dopamine. Dopamine agonists might be used adjunctively or as monotherapy on their own without any other medications to provide benefit and reduce symptoms.
Excellent. Great. Another question from one of our webinar attendees is, does strenuous exercise, quote unquote, burn through the carbidopa levodopa quicker, which invokes off quicker? And you actually burn through that and cause the medication to be metabolized quicker if you're intensely exercising?
Well, I can tell you in my clinical experience, I hear that from patients, that on days where they are expending more energy, right, they might actually note that they're wearing off potentially more. It's almost like I have not uncommonly heard this from patients, and that's kind of more clinical experience, kind of what I've heard from just we have 12,000 patients in our clinical practice, very big Parkinson's center. We're very busy. We have a high volume, and you got it. I've heard that, and it's not uncommon for me to hear that. Now, it's possible that maybe when we're trying to exert ourselves, we're noticing that maybe we're wearing off, rather than if we were just sitting there, not really exerting ourselves, maybe we wouldn't necessarily feel that wearing off effect as strongly. Or it's possible, you're right, with expenditure of energy, your metabolism, your cells are using the energy that you have, and our medications help us. But it's possible that we are kind of somehow, in certain cases, kind of exhausting some of that energy capacity that we have. Excellent.
Good. This is not in the clinical journals, but you're hearing it first here, folks, from clinical experience. So next question is, when off time occurs late in the afternoon, would adding a late afternoon dose of levodopa be as effective as switching to an extended release dopamine?
So there are different ways of evaluating off time, right? And if we're seeing that throughout the day, we have a predictable experience where we are wearing off of our medicine, or we're feeling like a certain time of day, we can predictably say, hey, I know I'm wearing off, right? This is it. I found it. This is the time. It's not unpredictable. It may or may not be intolerable, right? Those are the two factors that kind of, when we have those two questions in the back of our mind about when we add therapies, it's not uncommon for us to do two things at once, right? It's a dynamic condition. And sometimes we need a dynamic strategy. So we are thinking about, now that we have all these categories, definitely, hey, how do we improve our off time, improve our on time, reduce our off time? Extended release formulations of carbidopa levodopa, for example, right? Those are ways that we can help prolong duration from our previous dose. Data has shown that the more extended release formulations of carbidopa levodopa, like if you think about Rytary, it actually can show, based on clinical data, extended duration after each dose in comparison to the immediate release carbidopa-levodopa, if dosed right and done properly. Now, what about patients that we have that in the back of our mind where we're thinking about extended release formulations of carbidopa-levodopa? Maybe we've added an adjunctive to reduce off time, right? These on extenders or on augmentors, the different families that we mentioned. But we're also maybe thinking in the back of our mind, well, let's have an action plan similar to what an asthmatic might have, right? You have, or a diabetic person might experience, right? How do we combat these sugar fluctuations that, despite being on multiple formulations of medicine that might tackle diabetes, we still might need an as needed plan to kind of modify that sugar level. Same goes for asthma. We might have our patients on 3 or 4 different doses or different medications for maintaining or preventing asthma crises. But if you have an asthma crisis, there's an action plan there to help reduce the symptoms.
Well, great analogy. Yeah. Now we can start using an asthma protocol for maintenance versus as needed. That's excellent. Yes. Looks like we're going back on our next question to diet. You struck a chord with the protein and says, how much time should you avoid protein before and after eating to allow maximum absorption of the levodopa?
Yeah. So yeah, it's a good question. So it's a good question. And it's about, so what we tend to say in patients that might be experiencing that is protein, if taken within half an hour to an hour of taking your carbidopa-levodopa, may actually reduce the benefit from those doses. And so we tend to say, try and space your carbidopa-levodopa half an hour to an hour away from eating a protein-packed meal. Perfect. What I tell patients, though, is if you're hungry and you got to eat, you eat, right? And maybe think about that, knowing that it's protein mainly. Try and find out, what are those meals that may not have a lot of protein, so that you can maybe eat something, but it may not affect your absorption or benefit from carbidopa-levodopa.
Sure, yeah. Have a big salad with lots of vegetables and a little bit less protein.
Yeah, that's a good thought.
Next question is about sundowning. So my father is having some evening symptoms that we thought were an extreme off period, but an experienced in-home caregiver is suggesting maybe a sundowning effect. Can you speak to the difference between off symptoms and sundowning?
Yeah, great. And they could be the same. It's possible, just as it is it's a multi-layered process, right? And that's why it's possible that in the evening hours, we might be seeing an increase of neurobehavioral changes, right? So it is important to distinguish sundowning from an off episode. And it's possible that there's a cycle there, right? That maybe anxiety and panic is setting in because of a wearing off episode. And that can kind of then trigger some neurobehavioral changes that seem like confusion or brain fog. Those things can be, sometimes they're non-specific, so they could be wearing off. But sundowning is an important topic to discuss, because cognitive change is also part of our condition in certain cases. And so it's important always to evaluate your patient's cognitive state, their abilities, their cognitive abilities, their neurocognitive kind of level. If there's cognitive impairment or if there's dementia, we may be more prone to sundowning or confusion in the evening hours. And it's important to know that, because if we have cognitive impairment detected on either an MMSE or a Montreal Cognitive Assessment, those are ways that we can determine our patient's cognitive status. Let's not forget psychosis, right? When we think about psychosis, it can be part of our condition and can be made worse or caused by our medications. And so understanding the cognitive overall, all those components is very much a part of understanding our movement disorder. You need to know about your cognition in order to help your movements, and vice versa.
Yep. Sounds like a balancing act.
Right.
You had talked about this a little earlier. How much wearing off should you tolerate before increasing your carbidopa-levodopa? Do you worry about obviously dyskinesias caused by the higher levels? How do you strike that balance, or is it a very personal thing?
Yeah, you're right. And that's where it is personal and it's individual for each person, but there's different strategies. You might be able to think about a strategy to help reduce dyskinesias and improve off, right? So there are medications that we might think about for that. There's FDA indicated medications that are FDA indicated for both, right? So a medication like an amantadine derivative might be thought of during that time. But there's different ways of thinking. You can even sometimes lowering the dose of levodopa and making it more frequent, thinking about extended release formulations, adding on extenders, those adjunctive medications that we talked about can be helpful. But sometimes then we push ourselves into that threshold of more dyskinesias. And that's where, whenever we're having a tough time with our combination therapies or just our therapies in general, finding our way to thread that needle into a narrow therapeutic window where small changes make big impacts. That's a very important conversation to have and understand, because that's exactly when we start having that conversation about surgical treatment modalities, right? So it doesn't mean we're not going to still think about optimizing our oral medications, but we might really start thinking and having that conversation about, hey, these are the options for surgical treatment modalities. Which ones make more sense, given the individual?
Yep. Personalized approach. So what meds may be coming down the pike that can help with OFF? Anything in development that you've been hearing, your clinical trials or in your network?
So there's plenty of, so this is one of my favorite things, is to talk about the momentum in clinical research, right? So as an academic neurologist, we have one foot in clinical research at all times. And we have to think about this as an ever-changing field, as a dynamic field, and as a field that has all this research momentum behind it. And we've talked about everything that we can prescribe in clinic, but you got it. There's so much going on. We have clinical research, multiple sites throughout the country looking at an extended release formulation already of an extended release formulation of carbidopa levodopa. We have, so maybe a medication that might be in the future taken less frequently, but maybe, successfully, of course, we still don't know, but maybe we'll take it less frequently and get similar benefits to a more immediate release alternative that's given more frequently. We have different types of devices, right? We have a dopamine agonist subcutaneous pump that is being studied in the United States. And we also even have a subcutaneous carbidopa levodopa device that's subcutaneous, meaning in the skin, that might be able to deliver continuous infusion of carbidopa levodopa. That's not to mention all the other clinical trials looking at how to target the proteins within the brain that are causing the problem, and all the other clinical trials that have to do with devices, implantable devices, and where to target in the brain. So there's a lot here in movement disorders and in neurodegenerative diseases that's being studied.
So exciting. Love it. Couple more personal questions. I have off times when I don't move much for a long time, like when I'm watching a movie. Is this common?
Well, what happens sometimes, also in my clinical experience that I hear from patients, is that when we have long periods where we're not moving, sometimes we can kind of feel rigidity and stiffness set in, and so it can feel a little bit like, to get moving again, you kind of have to feel fluid again and less stiff and rigid. You kind of have to walk and stretch out those muscles. And you're right. So you can combat that with exercise, stretching, core exercises, things like Tai Chi, things that are going to be good for your core. Stationary biking is something that's both safe and effective. But yes, it also could be a wearing off episode, right? So stiffness and rigidity can be a sole symptom of wearing off. And that's where a strategy of kind of writing down when you take your medicine throughout your day and how you feel on an hourly basis can be very, very effective. That's a nice, effective communication tool. So be able to kind of hand your healthcare team a picture of what you might be experiencing.
Ah, interesting. Excellent. My husband has fatigue when he is off. What can he do?
Yeah, fatigue is a symptom that may have many causes. So when we think about it, we really have to kind of put it all together and try our best to determine that if fatigue is part of off, then we can target off and maybe fatigue improves. It's also possible that fatigue may actually be a symptom of low blood pressure, right? So low blood pressure can happen in Parkinson's, might cause fatigue. Fatigue can also be caused potentially by if you eat it can happen to anybody. If you have a big pasta meal at lunchtime, carbohydrates can make it so that all the blood from your body goes to your brain to absorb all that food, and carbohydrates are usually harder to absorb. And that can lead to fatigue too. So it could be induced by food. Another type of fatigue can be caused by just overall tiredness, right? Low energy. That can be part of Parkinson's disease, kind of hard to pinpoint. Or we really, really need to think about, remember I said, let's not forget sleep. We think a lot about our daytime, but what about our nighttime? Remember, Parkinson's patients might have sleep apnea, and that might make them feel fatigued or somnolent during the day. They might experience REM behavioral sleep disorder. They might act out their dreams, making them sleep less soundly. And then that sleep fragmentation, right? If you're waking up several times at night because maybe your dopamine levels are low, right? Because that's what can happen overnight, or you need to go to the bathroom a lot, urinate, that's going to contribute to daytime fatigue. And so you got it. It's so many factors. And that's why you kind of have to think about everything as a whole and get to the bottom of each one.
Right. And that actually leads to the next question. If insomnia is an off problem, how is that treated?
Yeah, so you got it. And so insomnia can be an off problem. Restless leg, can be something that we feel. It's kind of like a sensory issue that can happen where we feel like it's hard to control our leg or feel a discomfort. That could be a wearing off episode. So wearing off prior to bedtime sometimes can contribute to sleep onset insomnia, right? And we have to distinguish between sleep onset insomnia and then maintenance insomnia in the middle of the night. Sometimes our patients can fall asleep easily, but then they wake up predictably at the same time every night. Or maybe there is a pattern there. Maybe their last dose of carbidopa levodopa was at 6 p.m., but they're going to sleep at midnight, right? And that's been a long time potentially. And if you're uncomfortable, you're not going to sleep. You're not going to be able to fall asleep easily. And then a third point is depression and anxiety can very much affect our ability to fall asleep and stay asleep. And so if we're not screening for depression and anxiety, then we might be in trouble, because you kind of have to, in order to regulate your circadian rhythm, you have to tackle anxiety and depression too.
Absolutely. Next question is, does chewing medication help decrease wearing off? Do you have any suggestions as to what to take levodopa with to enhance efficacy, prevent, or help with off episodes? And this person has said, I've tried vitamin C, orange juice, as well as carbonated drinks, which sometimes help. So how can they take their medication differently? Yeah,
I'm not sure necessarily about the true clinical trial data, but you got it. We use strategies, right? We think about it. So in carbidopa levodopa's case, in immediate release, maybe we would tell patients, chew on some carbidopa levodopa, maybe think about drinking something with it like orange juice or lemonade, right? Because maybe there's something in terms of that acidity or citric acid that might help with absorption potentially, right? Maybe. So that's something that we used to try. There are different formulations like Parcopa. Sometimes that patients might feel the oral disintegrating tablet of carbidopa levodopa, but again, still goes down the GI tract. So we're still, even though we are doing those strategies with oral therapies, we sometimes, we're still reliant on that absorption in the small intestine. So our GI tract does still need to be functioning properly. Rytari is actually a medicine that's encapsulated that you can actually, in patients that have difficulty swallowing, you can open the capsule, sprinkle that into something like applesauce, and take it in patients that are having trouble swallowing. But those are things that we think about, just in clinical practice, depending on each scenario we run into.
Perfect. One question here, does off feel different if you're taking a dopamine agonist instead of carbidopa levodopa?
Well,
it could be personal.
Good. Yeah. Well, the answer I have is, I don't know. I know that we know the half-lives based on clinical research. Half-life is how long each medication administration, if absorbed properly, is in your system, right? So we know that carbidopa levodopa might have a certain half-life, and so which means it's out of your system after a certain amount of time. And so it might not be giving you benefit. We also do know that about dopamine agonists. So you can, if you're taking an immediate release dopamine agonist, the ones that are given 3 times a day orally, then you actually might feel that dopamine agonist wear off too, just like you would carbidopa levodopa. But that's where potentially, depending on each case, of course, we really start thinking about more extended release formulations of both carbidopa levodopa and dopamine agonists, right? So or we think about those on augmenters or extenders, the newer COMT inhibitors, A2A receptor antagonists, those combinations of how is it that based on all the clinical research, these adjunctive medications that are added to carbidopa levodopa that might extend on time and reduce off time.
Great. And the last question we'll go with today this is a general one. Get ready. Please explain the 3 kinds of deep brain stimulation surgical treatments.
Yeah. So yeah, I'd love to. This is a 3-hour lecture, right, Dr. Costantini?
Right.
I would love it to be. I can't believe it's
the last one for last.
I can't believe it's the last question already. Time flies. So thanks for making it so fun, everybody, and Dr. Costantini. But you got it. So there are 3 right now readily available in clinical practice, at least that I know of. We have Medtronic, we have Abbott, and we have Boston Scientific. And we might think about the different technologies differently. So Medtronic has what's called a closed loop system that can help us actually potentially understand some readings from the brain potentially. So there might be some data that might be captured by the device. Now, what that data really translates into right now, that's TBD, right? To be determined. But there is a capacity for Medtronic devices to actually capture some electrical information from your brain after being placed. A deep brain stimulator like Boston Scientific, actually, there are 8 contact points. So 8 places to stimulate in comparison to 4 contact points for alternatives. So that might be something that's might be seen in a Boston Scientific deep brain stimulator. And the Abbott device has directionality, and they do remote programming. That's something that's newer to them, is being able to program a patient remotely through their tablet. And so they do have approval to do that. And so each system has its pluses, but their effectiveness really, is tried and tested through clinical research. And before anything is FDA approved, of course, they go through a huge vetting process of safety and efficacy. But each device may have different pluses and minuses at any given moment. But of course, technology is constantly evolving, right? Technology moves faster than this lecture, right? With something new in technology might have come out just in the past 50 minutes where we've been talking. And so all these different devices might evolve, and each company might have different things in comparison to the other at any given moment in time.
Excellent. Well, thank you so much, Dr. Torres-Yaghi. This was so informative, and you made everything so easy to understand. You truly have a gift for teaching.
Thank you.
Thank you for joining us for this episode of the Parkinson's Podcast. For more information about the Davis-Phinney Foundation and to learn about educational offerings and community events for people affected by Parkinson's, please visit davisfinneyfoundation.org or dpf.org. This podcast includes information about Parkinson's and insights from our Parkinson's community. It is not intended as a substitute for treatment advice from your own medical providers.